When someone receives an ALS diagnosis, many believe rehabilitation is pointless. Why try if everything will deteriorate anyway? This belief fundamentally misunderstands what rehabilitation truly means. Rehabilitation for ALS isn't about reversing the disease, but making every day of life as comfortable, dignified, and meaningful as possible. ALS, Amyotrophic Lateral Sclerosis, is a neurodegenerative disease where motor neurons progressively deteriorate, causing muscle weakness, atrophy, difficulty speaking and swallowing, and eventually respiratory failure. Average survival after diagnosis is 2 to 5 years, though some live much longer. Medications like riluzole and edaravone slightly slow progression, but cannot stop the disease. This is where rehabilitation becomes crucial, not as cure but as essential support for quality of life. Rehabilitation for ALS focuses on 3 key areas: preserving remaining function as long as possible, introducing compensatory methods through assistive devices and communication tools, and modifying daily life through environmental adjustments. Research shows early rehabilitation intervention extends the period of maintained activities of daily living scores. A common concern is whether exercise might worsen ALS. This is true only for excessive exercise. Research shows low to moderate intensity exercise actually improves quality of life. Dalbello Haas in 2007 showed light aerobic exercise and strength training improved and maintained function without causing harm. The most important principle is maintaining choice and autonomy. Rehabilitation supports people's ability to make their own decisions. This support changes over time. When breathing becomes difficult, choices involve positioning or ventilator options. When swallowing becomes challenging, discussions cover oral intake, methods, or feeding tubes. These preserve dignity and self-determination. Multidisciplinary team approaches are essential. Physical therapists, occupational therapists, speech-language pathologists, nurses, nutritionists, and social workers must collaborate as challenges change with progression. Occupational therapists redesign daily activities, modifying environments, introducing assistive devices, supporting communication device setup, and teaching energy conservation. Early introduction before abilities are completely lost preserves self-esteem. Speech-language pathologists support swallowing and communication. For swallowing, they assess aspiration risk, teach safe postures, adjust food consistency, and provide psychological support. For communication, they introduce augmentative and alternative communication, including tablets, eye gaze devices, and transparent letterboards. Ball in 2001 showed early communication support, reduces depression, and maintains quality of life. Respiratory therapy addresses posture and positioning management. As breathing muscles weaken, rehabilitation offers interventions, including postural drainage and secretion clearance, mechanical cough assist devices, and position changes improving lung ventilation, non-invasive positive pressure ventilation using mask-type ventilators, relieves breathing difficulties. Bork in 2006 showed early NIPPV introduction, extended survival, and improved quality of life. Exercise principles for ALS focus on avoiding overuse, preventing residual fatigue, utilizing remaining function, and respecting enjoyment and comfort. Pinto in 2012 showed low to moderate intensity. Exercise improved quality of life without worsening fatigue. Appropriate exercises include range of motion training, preventing contractures, stretching, maintaining chest flexibility to preserve respiratory function, light resistance training for stronger muscles, and aerobic exercise, maintaining cardiopulmonary function and mental vitality. Exercise benefits extend beyond physical function. Braga in 2018 showed individualized exercise programs, reduced anxiety and depression while significantly improving quality of life scores. However, not moving creates risks, including joint contractures, pressure ulcers, increased aspiration, pneumonia risk, hypoventilation, and depression with social isolation. Continuing to move within. Fatigue-free ranges become central to rehabilitation strategy. Assistive devices preserve life functions by preparing alternatives before complete loss. International guidelines recommend early introduction. Examples include adapted utensils for eating, Velcro clothing for dressing and bathroom, aids for toileting and bathing. Even when hands become unusable, environments operated by eyes, voice, or single switches maintain life autonomy longer. Communication support technology has evolved dramatically. Staged introduction progresses from handwriting to transparent letterboards, switch input aids, eye gaze tablets, and speech synthesis apps. Beukelman in 2015 showed early AAC introduction helped maintain communication abilities long-term. Smart speakers and IoT home appliances expand self-operated ranges through devices. Controlling lights and air conditioning, IoT beds, enabling position changes and computers operated by gaze or head movements. The feeling of accomplishing something yourself, however, small, supports dignity and motivation. ALS rehabilitation means continuously expanding people's capacity to act, directly connecting to daily quality of life and psychological stability. End-of-life care requires respecting how patients want to spend their time and what care they desire. Choices arise between non-invasive ventilation, allowing conversation, versus tracheostomy, providing stable management, but making vocalization difficult. Consistently important is explaining available options and respecting individual wishes. For swallowing difficulties, feeding tubes prevent complications, but eating represents human enjoyment beyond nutrition. Efforts support oral pleasure, including tasting small amounts, and providing freshness through oral care. Advanced care planning is crucial for capturing and sharing patient wishes, with teams covering ventilation decisions, feeding tube preferences, pain response policies, and how to face death. Having time to discuss helps. Both patients and families feel they chose their own paths. ALS cruelly strips away daily abilities, yet what we can do to protect personhood, pride, and hope is far from insignificant. Rehabilitation for ALS is not meaningless. Preserving movement range, protecting eating pleasure, supporting means to express thoughts, using comfortable positions and equipment, and continuing to support self-determined choices, all represent the core of quality of life approaches and rehabilitation's greatest role. Please subscribe to our channel and hit the like button. Thank you for watching. Please subscribe to our channel and hit the like button. Thank you for watching.